After studying this module, you shall be able to know the symptoms of depression, understand the epidemiology of depression, develop an understanding of various causes of depression, and also to know the types of treatment available for depression. First, we must understand what are mood disorders. Mood is referred to as sustained emotional states, not merely to affective expression of transitory emotional state. Normal persons experience wide range of moods. Mood disorders involve much more severe alterations in mood and for prolonged period of time. These alterations are intense enough to cause maladaptations in relationships and work performance. The two key moods are depression, characterized by feeling of sadness and dejection, and other mood is mania, which involves intense and unrealistic feelings of excitement and euphoria. These two mood states are at opposite ends of continuum, with normal mood states being in the middle. In this chapter, we are going to discuss about unipolar mood disorder. In unipolar mood disorder, which are of more frequent type, the person experiences only depression, while in bipolar disorder, the person experiences both manic and depressive episodes. They are remarkably diverse in their features, but share a focus on excessive mood that colors and distorts the way the person thinks and views the world, accompanied by a changed level of movement, activity and energy, disturbed patterns of sleep and appetite, and altered motivation and engagement in the world. It is also important to differentiate the mood disorders by 1. Severity, the number of dysfunctions and intensity of impairments experienced in various domains of life. 2. Duration, whether the disorder is acute, chronic or intermittent. Some disorders of mood are apparently understandable reactions to life's adversities, while others may seem baffling in their origin and accompanied by the psychotic departures from reality. There are 4 key features of diagnosis of depressive disorder, which are presence of more than depressed or negative mood requiring a variety of additional syndrome manifestations, duration over a period of weeks or months to distinguish depression from temporary mood shifts, and impairment indicating that the depression interferes with the normal functioning. The 4th feature is critical to distinguishing between unipolar and bipolar mood disorders. There must never be a past experience of manic or hypomanic episode. Only then could a person receive a diagnosis of unipolar depression. The central features of all depressive conditions include emotional, motivational, cognitive and psychomotor changes as follows. Emotional manifestations. These include like sadness, anhedonia, tearfulness, hopelessness, feelings of guilt and feelings of worthlessness. Then we have motivational manifestations such as increased dependency, low energy, fatigue, apathy, poor concentration and loss of interest. Then we have cognitive manifestations like negative expectations, negative self-concept, exaggerated view of problems, attribution of blame to self, difficulty making decisions, suicidal ideations, thoughts about death itself, abnormal preoccupation with bodily illness. Psychomotor manifestations include disturbances in appetite and or weight, disturbances in sleep rhythm, which may include difficulty in getting off to sleep, frequent waking or hypersomnia, reduced libido, early waking, diurnal variation in mood, which becomes worse in the morning. Then unipolar disorders also have bodily manifestations like irregular menstrual cycle, amenorrhea, which is cessation of menstruation, or constipation. First unipolar disorder that we are going to discuss is major depression. It is the fourth among the 150 disease burdens to society. DSM-4 gives the following criteria for a major depressive episode. 5 or more of the following symptoms need to be present during a 2-week period. At least one of the symptoms is experience of depressed mood nearly every day, all day, or loss of interest or pleasure. And at least 4 of the remaining 9 symptoms covering a range of cognitive, physical and behavioral changes, which are depressed mood, loss of interest or pleasure, poor or increased appetite or weight loss or gain, insomnia or hypersomnia, psychomotor agitation or retardation, loss of energy or fatigue, feeling of worthlessness, guilt or self-reproach, poor concentration or indecisiveness, thoughts of death or suicide attempts. Next is dysthymic disorder. This is a milder chronic form of depression that includes depressive experiences lasting for at least 2 years, accompanied by 2 or more of 6 milder depressive symptoms. In some people, it may last as long as 20 years. This includes the presence of impaired functioning in the person's important roles. Some individuals may experience double depression, a pattern observed in about 25% of the clinical patients in which major depressive episodes are superimposed on dysthymic disorder, and especially adverse disorder in terms of course and impairment in adults. Then we have seasonal affective disorder, which is also called SAD or SAD. It was recognized as a distinct disorder by Rosenthal. The characteristics of SAD include depressive symptoms such as sadness, decreased activity, anxiety, work problems and daytime tiredness. Along with these may be increased sleep, poor quality of sleep, decreased libido and increased appetite with carbohydrate craving, in turn increased weight. DSM-4-TR describes SAD as having a regular temporal relationship between the onset of an episode of depression at a particular time of the year. Full remissions occur at a regular time of the year. 2 major depressive episodes that fit these criteria have occurred in the previous 2 years. Any seasonal depressive disorder outnumber the number of no seasonal episodes of depression. Then we have other types of depressions. Depressive experiences may include subsyndromal symptoms that are milder or briefer than these 2 diagnoses, or that are intermittent but frequent, or that are mild but enduring. There could be following types of depression. Primary depression. It is said to occur in someone with no prior history of any other psychiatric diagnosis. Secondary depression, on the other hand, refers to depression arising subsequent to the onset of superimposed upon other psychiatric or medical condition. Atypical depression. 3 main components include oversleeping, that is hypersomnia, deep fear of personal rejection and a tendency to emerge from depressed state when something good happens. In melancholic depression, there is inability to react positively to upbeat situations and things. This is commonly worse early in the morning and feels a bit like grief but far deeper. While in psychotic depression, individual experiences the symptoms of a major depressive episode along with 1 or more psychotic symptoms including delusions and or hallucinations. Delusions can be classified as mood congruent or incongruent depending on whether or not the nature of the delusion is in keeping with the individual's mood state. Common themes of the mood congruent delusions include guilt, punishment, personal inadequacy or disease. An endogenous depression is said to arise without any obvious external precipitating factor and is therefore thought to be biological in origin and responds better to somatic treatments, whereas a reactive depression or exogenous depression is believed to arise in response to external factors, for example bereavement, and do not necessarily differ in symptoms from those that do not. Moreover, it is rare for any depressive episode to be totally devoid of external precipitating factors. The postpartum period has been associated with an increased risk of depression. Postnatal depression usually refers to the depressive state, the severity of which falls roughly between the so-called baby blues and puerperal psychosis, which affects 1 or 2 per thousand women. Recent epidemiological research suggests that approximately 1% of the women suffer from non-psychotic depression following childbirth. Epidemiology of depression. Prevalence. The lifetime prevalence of major depression is 10 to 25% for women and 5 to 12% for men. It is less common among children and adolescents than it is among adults. Prevalence rates of depression in pre-adolescents range from 0.5 to 2.5% and in adolescents from 2 to 8%. Depression is equally common in pre-adolescent boys and girls, but more common in post-adolescent females than males. It is generally comorbid with dysthymia, anxiety disorders, substance abuse disorders, eating disorders and borderline personality disorder are common in major depression. Age of onset. Young women have enormous liability for depression onset between ages 15 and 19, while 50% of the patients experience onset by the age of 25 years. And risk of the first episode is significantly higher before the age of 40. A childhood depression may reflect marked emotional and behavioral dysregulation. In contrast, several follow-up studies of adolescent onset depression have shown relatively high risk for recurring episodes in adulthood. Length of episodes. Majority of episodes appear to resolve within 6 months, as shown by longitudinal studies of the natural course of unipolar disorder. 55% of the patients recovered by 6 months. However, a substantial minority of depressions persist for long periods and may be even chronic. Risk for recurrence of depression. More than 80% of depressed adults experience at least one recurrence. Recurrent episodes of MDE last about 20 weeks. According to World Health Organization, over 10 years, affected individuals experienced a mean of 2.7 episodes of major depression and spent an average of 27.5% of their lives in the depressive episodes. Another observation is that each recurrence increases the probability of further episodes. Solomon followed patients over 10 years period and found that the probability of recurrence after recovery from the index episode was 25% in the first year, 42% by 2 years and 60% by 5 years. Marital status. Generally, unipolar depression is more common among those with impaired interpersonal relationships or those who are widowers, divorced or separated persons. Social class. Higher rate of depression has been found among working class people, with a greater prevalence of depression in working class women. This difference could be due to the greater likelihood of certain risk factors. Sex differences in depression. The gender difference has been found in every culture at overall rate of approximately 2:1 ratio, indicating that unipolar depression is 2 times more common among women as compared to men. The gender gap appears to emerge in early adolescence, and the possible reasons could be the factors such as childbirth, hormonal disturbances and varying stress. Social and cultural factors. Some studies have indicated that unipolar depression is much more common in lower socioeconomic groups. Otherwise, mood disorder is equally common in urban and rural areas. Life events. Negative life events are more often than not present in unipolar depression. Example, loss of loved one, either by death or breakup, loss of job, etc. Now we have etiology of unipolar depression, wherein we have several approaches to discuss. First one is biological approaches, under which we first discuss genetic vulnerability to unipolar depression. Substantial data has been reported from investigations of family history or genetic variables for mood disorders. These studies are of 4 types: family studies, twin concordance, adoption studies and mode of transmission studies. First, we discuss family studies. Many studies have proven that depression runs in family. First degree relatives of the depressed patients have reported rates of depression ranging between 7% and 30% across studies. Having a parent with a depressive disorder is one of the strongest predictors of youth depression. And also there is a greater morbidity risk among the first degree relatives with prevalence rate being 20%. Twin studies show in several prospective as well as retrospective studies, a clear difference was found between monozygotic twins and dizygotic twins. Monozygotic twins had a 46% chance of being concordant for depression, while dizygotic twins had a concordance rate of 20%. Adoption studies indicated that examining 29 bipolar adoptive probands, it was found significantly more biological parents with mood disorders than adoptive parents, but these results have not been replicated by other methodologically sound studies. Transmission studies. Transmission does not follow patterns suggestive of a single dominant or recessive gene, and a polygenic transmission seems most probable. Psychoneuroendocrinology of depression. Hypothalamic pituitary adrenal axis or HPA axis. Several evidences implicate dysregulation of the human stress response of the HPA axis in depressive disorders. Elevated levels of cortisol, a hormone resulting in various forms of physical arousal and activation, as well as increased level of corticotropin releasing factor or CRF in acutely depressed people. Then we have hypothalamic pituitary thyroid axis. This is a highly complex and integrated network and is responsible for the release and regulation of thyroid stimulating hormone from pituitary. Studies show lesser release of TSH in depressed patients as compared to the normal controls. Melatonin. This hormone is secreted from pituitary gland and low levels of melatonin have been associated with depression. Vasopressin. It has been proposed that vasopressin function is decreased in depression. Neurotransmitters and depression vulnerability. There have been evidences of the potential role of deficiencies of neurotransmitters such as serotonin and catecholamines like norepinephrine and dopamine in unipolar mood disorders. These neurotransmitters are especially important in limbic system of the brain, areas affecting drives and emotions, and pathways to other parts of the brain. Neurophysiological changes. Abnormalities of the circadian rhythms affecting the sleep-wake cycle as well as cortisol and other bodily processes have been associated to mood disorders. Apart from delayed sleep onset, abnormal delta sleep, rapid eye movement cycles are disrupted in various ways. The most robust findings are reduced REM tendency, which becomes less than 90 minutes, and increased length of first REM period in depression. Functional and structural brain changes in depression. Studies based on neuroimaging, which may include EEG, MRI, fMRI, have reported some evidence of structural abnormalities in the brain of depressed people, such as reduced frontal volume. Some of the studies concluded that reduced metabolic rate and reduced blood flow are evident during depressive states, and consistent evidence of abnormalities in the functions of the prefrontal and cingulate cortices, areas that are closely linked with limbic and paralimbic structures. Depressed patients show relatively low level of activity in the left frontal lobe. Decreased left prefrontal activation represents reduced tendency to experience pleasure and positive engagement with the environment while enhancing the likelihood of depressive symptoms. Then we have psychosocial approaches of depression. Stressful life events. To explain this, we take help of diathesis stress model or dual risk model. The term diathesis means disposition or vulnerability, which is different for every individual, and it can take the form of genetic, psychological, biological or situational factors. Stress refers to a life event or series of events that disrupt a person's psychological equilibrium and potentially serves as a catalyst to the development of the disorder. Thus, the diathesis stress model explains that diatheses interact with the stressors to produce depression. Diathesis stress model asserts that if the combination of the predisposition and the stress exceed the threshold, the person will develop depression. Then we have a multiple risk factor model, which suggests that depression occurs in the context not only of stresses but also of chronic strains and diminished resources of coping, such as social support. There are several types of stressors such as situational stressors that tend to lower the self-esteem, like being fired or failing an exam. 2. Thwarting of an important goal. 3. Developing a physical illness. 4. Single stressor of overwhelming magnitude such as death of a child or a parent. Severe stressors occurring in series like breakup followed up by poor performance at work. Insidious stressors such as living with a depressed or physically disabled person who needs constant care. Chronic strains such as poverty or lack of resources, and severe childhood adversities such as physical or sexual abuse may predict adult histories of depression among women. At times, depressed people may generate stressful events as byproduct of their depressive tendency. Depressed women may have difficult relationship with their children and with their own spouses, and may lack the skills to deal with the problematic personal relationships. Brown and Harris have identified following vulnerability factors, which are not having a close intimate relationship with spouse or lover, having 3 children under the age of 5 years, not having a fulfilling job, having lost a parent by the age of 11. To understand the etiology of unipolar disorder, we also have certain perspectives, under which first we discuss psychodynamic perspective. In a classic paper, Mourning and Melancholia, Freud in 1917 drew a distinction between grief and depression, where the grief was understood to be the conscious reaction to a loss, while in depression, the true feelings of loss remain unconscious. In depression, there is anger towards a loved one because he or she is perceived to have rejected or deserted the individual, and the anger and disappointment previously aimed at the lost person are internalized, so lead to a loss of self-esteem and propensity for self-criticism. This destructive wish in turn gives rise to feelings of guilt. It was further suggested that the loss of appetite so often observed in depressed people is a defense against the hostile wish to incorporate the loved person. Bowlby in 1981 suggested the importance of early attachment and proposed that the insecure attachment leads to pathological responses to interpersonal events. 2 personality types, anxiously attached and compulsively self-reliant, predispose a person to depression. Early separation and losses have been found contributing to depression. Then we have behavioristic explanation. Forster in 1973 asserted that depression can be equated with a state of extinction from positive reinforcement or an increased rate of negative reinforcements, leads to the reduction in effort and activity, which further result in even lesser chances of coping with aversive conditions and achievements of need gratification. According to this theory, there are 3 ways in which insufficient reinforcement may occur. The environment may be inadequate in providing sufficient reinforcement to maintain adequate functioning, for example, loss of a job. Second, the person may lack the requisite skills to obtain reinforcement in an environment. For example, poor interpersonal skills might prevent a person from developing satisfactory social relationships. 3. Reinforcement is available to people, but they are unable to enjoy or receive satisfaction from them. The reason for this condition would ordinarily be interfering anxiety. Cognitive explanations. First cognitive explanation was given by Beck in his cognitive theory. According to Beck in 1963, our conscious thoughts are distorted by underlying unconscious depressogenic schemata or dysfunctional beliefs that are established during childhood. They influence what Beck referred to as the cognitive triad, which include beliefs about self, beliefs about world, and beliefs about the future. Negative events in childhood such as parental rejection establish negative cognitive schemata about the self and the world. When we encounter stressful circumstances in adulthood that resemble previous childhood experiences, due to which underlying negative schemata are activated and start to influence our surface cognitions and lead to depression. Beck identified 2 personality variables. Some individuals experience personal worth as deriving from the achievement of highly valued goals and control, that is autonomy, whereas others are more likely to invest themselves and their self-definitions in personal relationships with others, that is sociotropic. Negative events occurring in the vulnerable domain may be specially interpreted as depletion of the sense of worth and competence leading to depression. Learned helplessness theory. Martin Seligman in 1974 proposed that when an organism is encountered with uncontrollable and aversive event, he develops learned helplessness, which leads to three kinds of deficits: motivational deficits, cognitive deficits, emotional deficits. And these three deficits put together can lead to depression. Attribution theory. Abramson, Seligman and Teasdale in 1978 suggested that there are following attributions that people make about uncontrollable events, which are internal, external, global or specific, stable or unstable. Depression vulnerable individuals habitually attribute negative outcomes to internal, stable, global causes and positive events to external, unstable and specific causes. Then we have hopelessness theory of depression, which was given by Abramson in 1989. This theory emphasized the idea that attributional style is a contributory cause or a risk factor along with hopelessness. Pessimistic attributional style can be a vulnerability factor when combined with the hopelessness expectancy and serve as a risk factor. Then we have to discuss various treatment modalities available for depression, under which first ones we have is biological treatment, wherein we have pharmacotherapy. Principal indication for the use of antidepressant drugs is major depression. There are several effective tricyclic drugs which have been available for the decades for the management of depression. Apart from that, there are various selective serotonin reuptake inhibitors or SSRIs. These are better tolerated and have fewer side effects and are less toxic in large doses. Then there is electroconvulsive therapy or ECT. Because antidepressants take few weeks time to produce significant improvement, ECT is sometimes used with severely depressed patients who may present an immediate and serious suicidal risk. This approach of treatment combines the major principles of cognitive and behavioral theory. This focuses on helping the patient identify the causative, negative, cognitive and behavioral patterns and develop alternative, flexible and positive thinking patterns and rehearse new cognitive and behavioral responses. It makes use of several techniques like activity scheduling, graded tasking, ABC charting, self-instructions, etc. The data to date indicates that CBT is a very effective treatment for depression. Then we have interpersonal therapy. It focuses on the patient's current interpersonal problems which may be serving as causal or maintenance factor in depression. It has been proven to be a very effective treatment mode for the major depression. Then family therapy. Though this is not a primary therapy for treating depression, but it helps the patient to reduce and cope up with the stress and lessens the chances of relapse at times. Family dynamics and relationship patterns may be the maintenance factors of depression. Summary. Mood disorders occur because of dysfunction of mood or affective states. There are unipolar disorders like major depression, dysthymia, seasonal affective disorder. There are many subclinical depressions also like primary, secondary, endogenous and exogenous depression, postpartum depression, adjustment disorders, etc. Major depression is a unipolar disorder which represents several behavioral, cognitive and affective symptoms. This may often lead to suicidal ideations. There is epidemiological pattern of depression according to the prevalence, onset, age, gender, marital status and other risk factors. Various causes of depression include biological, psychosocial and situational factors. Several treatment modalities available are pharmacological therapy, which involves the use of antidepressant drugs, and psychological therapy, which includes CBT, interpersonal therapy and family therapy.